Here in this video I'll be dealing about the alpha-1 blockers, right, the selective alpha-1 blockers, and I'll be dealing about the non-selective alpha blockers also. We already understood that this alpha-1, right, it is present where it is present in external urethral sphincter, right. So you can observe this. Here is the position where the alpha-1 is present. And now we got some drugs. Why we have got some drugs? Because whenever I stimulate this alpha-1, it lead to constriction of these external urethral, that means the urethra which is present at that point, this constriction of that urethra, right? So since when I stimulate, the stimulated alpha-1a leads to the constriction and the retention of urine, I can use some drugs which can block this function so that he can urinate well. So the one alpha-1, right? So the alpha-1 blockers are, if you look at the first one here, that is silodosin, right? You got silodosin, alpha-leucin and tamsulosin. So I have already told you that you got a sin at this point here, osin. If it is osin, then it is alpha-1a. It is zosin, Z-O-S-I-N, it is alpha-1 blockers. So now let us understand in which all conditions we can give this tamsulosin, right, the alpha-1a blockers. So before that, you should understand something. Our prostate or the prostate gland, it is sensitive to something. So let us see the testosterone, right, in our body converted into dihydroxy testosterone in the presence of an enzyme 5-alpha reductase, and this dihydrotestosterone, it has got, and this testosterone, right, it has got that ability of stimulating this prostate gland, right, it has got that ability of stimulating the prostate gland. You can see at this is the prostate myofibroblast. So whenever the testosterone act on this fiber or the fibroblast in the prostate, it leads to, you can observe here, there is increase in size, right. So this is what you have to understand at this, right. So ultimately, once this testosterone act on this this fibroblast, it leads to increase in the size, in the sense hyperplasia. So it is what the benign prostatic hyperplasia. The moment it acts, you can see the chronic proliferation of this fibroblast that leads to hyperplasia. So whenever it is hyperplasia, you can see the prostate which is good enough, now it has increased, so it has compressed at this point. So the person who have got this enlargement of this prostate, there is difficulty in urinating, right. So these are the things you have to understand at this point regarding the first thing. So let us understand the second one here. The second one here is, you got a receptors at this point. So if that also activate, then that also leads to the obstruction of the urine. So right now we have to give some drugs so that we can relieve these symptoms here. The first one we are going to give here is to reduce, you can see this, we are going to give these finasteride, right. You got something known as finasteride. So what is finasteride? Finasteride is 5-alpha reductase. So this finasteride can act on the 5-alpha reductase. So now the dihydrotestosterone is not formed, there is no stimulation of this, there is no hyperplasia. And along with that, we can give this tamsulosin. We already know that tamsulosin is alpha-1a blockers. So when I combine them and give this finasteride act on the 5-alpha reductase, and this tamsulosin acts on this alpha-1a blockers, alpha-1a receptors, so it blocks that. So this tamsulosin is used for rapid symptom relief, rapid symptom relief by tamsulosin, because whenever I block this urethra dilates so that the urine can pass freely. So if you look at this finasteride, the main problem of the size, increase in size, is because of this hydroxytestosterone which is found by the testosterone in the presence of enzyme 5-alpha reductase. But this fenestrate is gonna block this or gonna stop this 5-alpha reductase, so there is no formation of dihydroxytestosterone, and now it is fine that there is no problem for the prostate, right? So the other thing you have to understand here is we got something here, right? I've told you this dihydroxytestosterone most active form here, so you have to be very careful here. So if you look at this fenestrate, it takes 3 to 6 months, right? It takes 3 to 6 months to reduce size of prostate. So that is the reason if you compare both the drugs, for the rapid symptom relief we're going to use this tamsulosin. For the fenestrate, because it's taking 3 to 6 months, it's late, right? So for that we're going to use this fenestrate. So let us understand the next one here. The next one is the male who has got the BPH, right, benign prostatic hyperplasia, who have got this, and tamsulosin. So you can see this. The tamsulosin is also used. One more thing you have to understand here is, and tamsulosin is also used for lower urethral calculus. So if you have any stones at this aspect, so that it further should not go down. So for that, so it has to go down in the sense. So you can see that when I block this, so you can see this, the blocked stone can come out of, right, so that it can prevent this obstruction at this point. So tamsulosin is also used for lower ureteric calculi, right? This is ureteric calculi, this is not the urethra, this is ureteric calculi. For these calculus we're gonna use this. So I told it's urethra, no, you don't give this. So it can be given for the lower ureteric calculi. So the next thing you have to understand here is, patients on tamsulosin undergoing cataract surgery may complicate floppy iris syndrome. That means patient on tamsulosin, if the person is on tamsulosin, if a person is BPH, right, is a male BPH, he is on tamsulosin, when he undergoes cataract, it can lead to, he'll get a risk of floppy iris syndrome here, right? You got something known as floppy iris syndrome during surgery here. So what is floppy iris syndrome? Floppy iris syndrome is nothing but it's a prolapse or the constriction of the iris during cataract surgery. The prolapse of the iris during cataract surgery is known as floppy iris syndrome, right? So let us go with the other things here. The next one you have to understand here is you got something known as these doxazosin and terazosin. I told you tera, doxa, pra, right, the alpha-1 blockers, they have got the apoptic effect on this prostate, right? They have got this apoptic effect, so they decrease the size of prostate. Actually, these alpha-1 blockers, see, doxazosin and terazosin, they are the alpha-1 blockers, right? They have got an apoptic effect on prostate. So what is this apoptic effect? Apoptic effect is nothing but death of cells which occurs as a control part of developing. So they are the death of cells, it decreases the size of prostate, right? So these are the things you have to understand at this point, and you can understand at this here. For this, the person who have got the elderly male BPH, hypertensive, right, or the person who have got hypertensive with BPH, the drug of choice is prazosin. So the person, elderly patients who have got this hypertensive with BPH, because prazosin is something when it is alpha-1 blockers, so it can decrease the blood pressure, and it also has got decrease the blood pressure. So for the person who have got this hypertensive with BPH, the drug of choice is prazosin. The young male with BPH, right, the young male with BPH, drug of choice is tamsulosin, because the main point is to relieve the obstruction of the urine. So for that we're gonna use tamsulosin. If it is elderly male with BPH, we're gonna give tamsulosin. If it is a young male with BPH, we're gonna give tamsulosin. If it is elderly male, hypertensive, the drug of choice is prazosin. So these are the important points you have to understand at this. So let us understand the next thing here. The next one here is we got something known as a non-selective alpha blockers, right? A non-selective alpha blockers can be for alpha-1 or alpha-2, But right now we have divided these non-selective alpha blockers, so it can act on alpha 1 or alpha 2. It's not specifically acting on one receptor, because since it is a non-selective, it can act either one alpha 1 or alpha 2. So if you look at the first one here, the first one is, we have divided these non-selective alpha blockers into two, that is irreversible and the reversible. If you look at the reversible here, you have got something known as talozoline, and you can see phentolamine. So you can see the talozoline and phentolamine. So this talozoline and phentolamine, right? If you look at this, it is an irreversible point. In the irreversible point, you have got something known as phenoxybenzamine, right? Phenoxybenzamine, it is the point you have to understand at this point. Phenoxybenzamine, it is irreversible phenoxybenzamine, right? So these are the important drugs you have to understand. Just understand the word tol here, just understand whether amine, and these also amine. So let us understand something regarding this phenoxybenzamine. So let us understand something regarding this pheochromocytoma here. In the pheochromocytoma, what is the pheochromocytoma? It is a tumor of adrenal medulla. You know that you have got an adrenal gland, adrenal cortex and medulla, and you got a cells over here. The tumor of this adrenal medulla is pheochromocytoma, and this release large amount of adrenaline here, right? They release large amount of adrenaline, right? So the large amount of adrenaline, they act on the receptors. You know that the tumor which is present in the medulla, they release large amount of adrenaline here. Adrenaline is a sympathetic, so that acts on its receptors. It can act on alpha 1, it can act on alpha 2, it can act on alpha beta 1, beta 2, right? But the thing you have to understand here is, for that the definite therapy is phenoxybenzamine. So if you look at this phenoxybenzamine, I have already told you phenoxybenzamine, it comes under irreversible, right? Irreversible and non-selective alpha blockers, So these, the definite therapy of choice for the hypertension due to pheochromocytoma is phenoxybenzamine. It's an irreversible non-selective alpha blockers, right? So that is fine. To control the intraoperative hypertension, right, the drug of choice is IV phentolamine, right? IV phentolamine, and you can see it can be used this IV in sodium nitroprusside. You know that this has got if you look at this phentolamine, I already told you here phentolamine, right? It is a reversible non-selective alpha blockers, right? So I have told you tolozocin and pentolamine, right? Pentolamine, it is reversible alpha blockers. So this is the drug of choice for the intraoperative hypertension. But if the hypertension is for the pheochromocytoma here, so definite therapy for the hypertension due to pheochromocytoma is phenoxybenzamine, the irreversible non-selective. But if it is a to control intraoperative hypertension, we're gonna give this phentolamine, right? And then sodium nitroprusside. What is sodium nitroprusside? Sodium nitroprusside, it's there for the relaxation of vascular smooth muscles, right? Vascular smooth muscles. And understand the next point written here. The next point written here is for treating pheochromocytoma, right? So propanol should not be given while treating hypertension due to pheochromocytoma. So let us understand that for treating pheochromocytoma, you know that right now the person has got an excess of adrenaline. It acts on alpha 1, alpha 2, alpha 3 neuron receptors. If you look at the propanol, should not be given as a first line therapy, because propanol is not a selective beta blockers, it is a non-selective beta blockers. They can block beta 1 and beta 2, right? They can block beta 1 and beta 2. Fine, if they block beta 1, it's fine, but if they block beta 2, they're gonna, since whenever we activate beta 2, it leads to dilatation of the blood vessels, right? So when I block that, it further increases the BP, because we are blocking this beta 2. The main function of the beta 2 is the dilatation of the blood vessel to relax, right? Relaxation of smooth vessels. But when you block this, it increases the BP. So it further it increases the BP at this point, unopposed vasoconstriction, yes, and it increases the BP. right? And you have to understand that beta blockers are given secondary to alpha blockers to control reflex tachycardia. So why we have gonna give beta blockers after the alpha blockers? You know that whenever we give alpha blocker here, so you can understand that alpha blocker, when I block, it decreases the BP. So decreased BP can sensitize these carotid bodies, and it can in turn tell the brains that there is a decrease in BP, you have to increase, so the heart increases its rate, so tachycardia. To block these, the beta blockers are given secondary to alpha blockers to control the reflex tachycardia, right? So let us understand the next one here. The next thing you have to understand is for operating tumors, right, halogen drug should not be given. You know that whenever you are operating here, so for operating Pheochromocytoma, so do not use this halogen. Do not use the halogen, because you know the halogen has got that ability of sensitizing myocardium for catecholamines. So they have got the ability of sensitizing the myocardium for catecholamines. So if they have got that ability of sensitizing the myocardium for the catecholamines, it can further aggravate and it can further increase the symptoms or further increase the heart rate. So these are the things you have to understand at this point regarding this. Halogen should not be given for the operating sense. It sensitizes the myocardium for the catecholamines, right? And the second thing you have to understand, you're not supposed to do the second option. When it comes to the PGA, you're gonna not give the ketamine also, ketamine, but the AIMS question can be of halogen. The AIMS question tells you it's an halogen. So AIMS halogen, right? These are the important things you have to understand regarding this ketamine, that is halogen, right? So let us understand the next one here. So what are the next thing you have to understand here is, the next one you have to understand here is, you can see the tumor of medulla here, right? So the tumor of medulla, if you look at the tumor of medulla here, so if you look at this right now, we are finished with the tumor of medulla, that is Pheochromocytoma. Now let us understand the tumor of cortex here. The tumor of cortex, you can see the adrenal cortex. The adrenal cortex, they secrete corticosteroids normally. A more release, excess release of corticosteroids can lead to Cushing syndrome, right? Cushing syndrome. So the drugs used in the treatment of Cushing syndrome, it can be all these metirapone, ketoconazole, mitotane, then aminoglutathione and trilostane, etomidate. So you can understand that the first drug we're gonna deal with it, it's gonna end with mitirapone, and next comes with the ketamine and mitotane. Then you can see aminoglutamine, and you can see trilostane, and you can see etomidate. So these are the very important drugs you have to understand regarding this treatment of treatment of Cushing syndrome. So these are the things you have to understand. In the next session, we'll be dealing about the other concepts. Thank you.